My name is Dr. Kyle. I'm a consultant rheumatologist here at North Devon. Apologies I can't be with you today, but I am unfortunately double booked and have to be at another meeting. But we thought it'd be a good opportunity to record this video so people could then look at it when they wanted, and we could also put it on our website. So I'm going to do a run through of some key bits of osteoporosis. Why do we bother about osteoporosis? Well, because people get significant vertebral fractures, and this lady here, who is a patient of mine, had one of the worst sets of vertebral fractures that I've certainly seen, and she had a lot of complications with regards to her medications, and many of her causes were due, of her vertebral fractures were due to steroid use over many years. But perhaps more importantly, what we're interested in trying to prevent this from happening. So this is a hip fracture, and we know that hip fractures carry with them significant morbidity and mortality, and although the data is getting better, about 1 in 5 people who have a hip fracture die within 12 months of having had the hip fracture. So if we can stop this happening, we stop people having the fracture, developing pneumonia because they can't mobilise, and running into problems. So that's why we bother. So what I'm going to do is I'm going to run through an overview of osteoporosis, exactly what it is and what we are talking about when we're mentioning it in the clinic, review some current clinical risk factors, look at current assessment algorithms. I'm going to talk to you about something called the FRAX and Q fracture, look at the National Osteoporosis Guideline Group recommendations, and then review current available treatment options here in North Devon, with a particular reference to what's now happened with Devon with regards to denosumab, a injectable treatment for osteoporosis. Very topically, we'll pick up on about bisphosphonate holidays, and then we'll talk a bit about some non-post menopausal osteoporotic indications, such as with men in particular. Okay. So, some of these facts are a little bit out of date, but they are still fairly relevant. Up to about 180,000 symptomatic osteoporotic fractures happen per year in England and Wales. Unfortunately, osteoporosis, as I will show later, is a condition of the ageing. So 50% of those fractures happen in people who are over 75. 25% of them happen in 65 to 74, and a quarter happen in 50 to 64. So there's a spread. Most of osteoporotic fractures in women, unfortunately, and I'll show you again why that happens, and in postmenopausal women particularly. So again, this is some data from a few years ago, but if NICE recommendations were adhered to for bisphosphonate use, this would cost the NHS about £33 million per year. And in reality, with intravenous treatments now available and other treatments, this number's significantly higher. It's important to remember that fractures happen, and they don't just happen in osteoporotic patients. So 85% of all fractures occur in people who don't have osteoporosis. So although we're talking mainly today about osteoporotic fractures, it is important to remember that fractures happen without osteoporosis. 50% of inpatients, when we audited this, patients who were admitted with low fragility fractures, so that's the definition of that is falling from a standing height without any gravitational forces behind. They, when they were in on the wards, only 50% of them were prescribed or recommended appropriate treatment on discharge. So we're still not great, but hopefully we've got an orthogeriatric team now, and so that's improving. And also when we audited it, we showed that 28% who should have been referred through for a DEXA scan, so a bone density scan, also didn't get referred through for a bone density scan. So, this is perhaps one of the key slides to take home with you today. So the top slide, the important one perhaps is the red line, and what you can see, you've got age here and you've got bone density on the y-axis. And you can see with women, as they get older, their bone density improves. So they get to their mid-30s and they reach what's called peak bone mass. So that's as good as your bone mass is ever going to be. And then you stay relatively stable through till you hit your menopausal age range. And at that point, you start losing bone mass quite quickly. So that's this downslope here, number 2. So you lose the bone mass quickly, and then it stabilizes out after that. But you've lost a significant amount of bone in that sort of 10-year window. If you compare that to men, in the black line, men reach a peak bone mass that's higher and it's slightly later, and they don't get that dip of postmenopausal bone loss. So actually the men and the women after that initial dip lose at exactly the same rate as each other, but it's that 10 or 15 year where they quickly drop off due to lack of estrogen drive in women that you lose your bone mass. So that's why women are more prone to osteoporotic fractures. So this is just a really nice image of bone. This is relatively normal bone over on the right hand side with a good cortical thickness and nice what's called trabecular pattern. That looks a bit like an Aero chocolate bar. Whereas on the right hand side, that's an osteoporotic bit of bone. So it's got a thin cortex around the outside and it looks like someone's been eating most of the Aero bar within it. Okay. So, and why is that important? Well, what we can see here is how fracture rate impacts morbidity and mortality. So, early fractures often might be falling, you fall onto your wrist, you break your wrist and you sustain a Colles fracture. That you tend to recover from very well and you have pretty normal function comes back. But as you get a bit older, you start having other fractures, you start having vertebral fractures. Many vertebral fractures can be completely asymptomatic. People don't know they've had them, but many are symptomatic, particularly with pain. And if you've had one vertebral fracture, your biggest risk for a vertebral fracture is having had one vertebral fracture already. So what you can see is that people tend to start getting sequential numbers of vertebral fractures. This leads to increased pain in the spine, loss of function in the spine and change in posture that then, in the severe cases like I showed with my first slide, can be really very marked with what's called a marked kyphosis or curvature of the spine. Then as you get older, unfortunately, this is the age group where hip fractures start to come into play. And as we said, 1 in 5 people from hip fractures die within 12 months of their hip fracture. So this is what we're really trying to prevent, and we're trying to keep people from having these multiple fractures. So just a little bit about building blocks. So calcium and vitamin D are obviously important. Most people who are on, or people who are on treatment for osteoporosis should be on calcium and vitamin D supplementation. Calcium supplementation, there's been a lot in the press over the years. Should you be on calcium? Shouldn't you be on calcium? Is there an increased cardiovascular risk with calcium? And I think the answer to that is, if you have sufficient dietary intake of calcium, then I think it's absolutely fine for you not to be on calcium supplementation. But if there's any doubt over whether you have a good dietary intake, and so that's around 1,500 milligrams of calcium per day for a postmenopausal woman, perhaps slightly lower in younger ages. So if you feel that you don't have enough calcium in your intake, then definitely we should be thinking about supplementing. Unfortunately, most of the supplements come as a combination, but there are on our formulary and on the Devon formulary different combinations of just calcium supplementation and in particular vitamin D on its own, so you don't need to take it as a combination treatment. And vitamin D, again, vitamin D is very difficult to get from dietary, so all vitamin D, or most vitamin D, actually comes from sunlight. We don't get a huge amount of it here in North Devon. We tend to get more rain and cloud, but May through to September, when the sun's high enough in the sky, the UV light rays are high enough and it synthesises vitamin D through your skin that then gets active through the kidneys and you make vitamin D. So dietary, some oily fish and things like that have reasonable amounts of vitamin D, but really if you're not getting enough sunlight exposure, you will not get enough from your diet. So you need supplementary benefit, and that's around, for a postmenopausal woman, around 800 international units. So common medication that you'll be prescribed by your GP, something called C-Cal D3, will have 1500 milligrams of calcium in it and 800 international units of vitamin D in it. This is an example of a bone density report here at North Devon, and we look at two particular things. So you'll see patient's age, and you get what's called a T-score, and you get what's called a Z-score. Now, this is purely a statistical calculation, okay? And what a T-score looks at is what your bone density is like compared to a fit, healthy 30-year-old. So if you go back to that original graph that I showed you with peak bone mass, the red line, and you think about what the peak bone mass of a woman at 30 is, that's what your T-score compares you against. So your T-score is what the WHO, the World Health Organization, used to classify whether you have osteoporosis. So if you're compared to a fit, healthy 30-year-old, and you are more than 2.5 what are called standard deviations, which are just a statistical calculation, away from that middle point, you have, by definition, osteoporosis. Okay? So your T-score of -2.5 is the definition of osteoporosis. T-score of -1 to -2.4 is osteopenia, and a T-score of better than -1 is normal bone density. Okay? So you can see in this example, we've got a T-score in the spine of -4.7, and in the hips of the worst is -4.7. So this patient has profound osteoporosis. Okay? Now we also do a Z-score, and a Z-score is helpful, and it's often more helpful in slightly younger patients. So what a Z-score tells us is what is your bone density compared to people of your age. So age-matched population. So if you're a 60-year-old and you've got a low T-score, but you've got a normal or a moderately low T-score of -1.5, that may be relatively normal for your Z-score. So for your age, it may be relatively normal. But that is not how we determine whether you have osteoporosis. It is always done on the T-score. Okay. So hopefully that's clear about bone density scans and how we determine those. So there's plenty of guidelines out there around osteoporosis and assessing osteoporosis and the risk of fractures. This was some guidelines from a few years ago in August 2012, and this was around assessing the risk of fragility fractures and starting to think about fragility fractures in a bit more detail. And what you can see is that it's targeting populations, because if you target populations, you have more impact, you reduce the chance of fractures, and that's where, being brutally honest, the cost saving comes from. So what they said is you should consider a fracture assessment in any woman over 65 and all men over 75, and in women under 65 and men under 75 who have significant risk factors. And those risk factors are previous fragility fracture, and we've already described what a fragility fracture is. Current use of oral glucocorticoids, so systemic steroids, prednisolone is the common one that we use, and probably a cut-off of around 5 to 7.5 milligrams. Below that, we're not quite so worried. Above that, there's a definite increased risk of osteoporosis. If you have a history of falls, if you don't fall, you tend not to fracture. So actually that's really important. People with underlying musculoskeletal problems, osteoarthritis, who find it difficult to walk, or people with underlying neurological conditions, may have had a stroke in the past. They're clearly at higher risk of falling. Very importantly, if you have a family history of a hip fracture, mum or dad, doesn't matter, then that's also very important, and it significantly increases your risk, and that's probably the highest risk factor for you having a hip fracture, which suggests that there's an underlying genetic component to low bone density as well. Other causes, these are medical causes, things like hyperparathyroidism, hyperthyroidism, poor low weight, difficulty with absorption such as celiac, liver disease, etc. Low BMI is obviously important. It's important that you have gravity through your skeleton. If you go up in space, you develop osteoporosis. So it doesn't matter what size you are, when you go up to space, you lose gravity. If you don't have weight through your skeleton, you develop osteoporosis. Smoking is important, but perhaps more important is alcohol. And if you drink more than 3 units of alcohol a day, that's a significant risk factor for osteoporosis. It's important to think about the age of the patient when you're assessing them for risk of fractures, but also all these other risk factors. So we've touched a little bit on some of these, some clinical risk factors. So as I said, some of these you can't do very much about. You can't do very much if your mum and dad have had a hip fracture. That's a genetic risk, and you can't do anything about that. You can't do anything about a previous fracture. But some of these you can modify, and you can try and treat as well as you can to reduce your risk. So we've already touched on age, you can't do much about that. Sex, women are more prone to fragility fractures and osteoporotic fractures, but you can't do much about that. Body mass index is important. People can increase their body mass index, and when you're younger, it's very important that your body mass index is sufficiently high that you maintain your menstrual cycle, because that improves your bone density. Previous fractures we've talked a bit about. Hip fracture we talked about. Steroids we've already talked about. Current smoking and alcohol we've touched on. And then there's this long list of medical conditions which increase your risk. And perhaps the one that most pertinent to myself as a rheumatologist is rheumatoid arthritis. For many reasons there's an increased risk. So rheumatoid arthritis is an inflammatory condition, and we know that any condition that is inflammatory lowers your bone density. Okay. We also know that patients with rheumatoid arthritis are often on glucocorticoids, so on prednisolone, which we've already said is a significant risk factor. And then people with rheumatoid arthritis have reduced mobility often because of their poor joints, so they've got risk of falls. So rheumatoid is a massive risk. People with problems with underactive sex hormones, so if you have low testosterone levels and things, particularly as a man, you may be more at risk of developing osteoporosis. Prolonged immobility, and then list of other things. Gastrointestinal, we talked a bit about celiac disease, which is gluten sensitivity, and chronic liver disease. And also obstructive pulmonary disease, COPD. These patients can often be underweight. They smoked in the past, most of them, and then they're also on long-term steroids, so their risk factors increase significantly. Okay. So this is taken from the National Osteoporosis Guideline Group recommendation, a sort of algorithm. So you assess the patient, have they got clinical risk factors? Yes, they have. You perform what's called a FRAX, and I'll show that on another page. And this gives a probability, a 10-year probability of whether your risk for a hip fracture or major other osteoporotic fracture. And then you get graded into high risk. On that alone, you don't need to have a bone density scan, you just start treatment. So if you've got lots of risk factors, you just start treatment. If you've got very few risk factors, you're low risk, or you don't need to do anything else, then you might recommend some weight-bearing exercise, strengthening, and we certainly use things like Pilates, and our physios will talk to you a little bit about things like that. But if you're intermediate risk, in that sort of grayer area, Then we go on to do a bone density scan on you, and that bone density scan allows us to determine your risk more, and we'll decide whether or not we treat you or it puts you in a lower risk group. So that's sort of algorithm when we've got patients in clinic, or Bev, our specialist nurse, is seeing people, that is in our head that we're sort of thinking about. This is an Australian one called the Q risk, and this gives you an idea because it does include previous fractures, but it doesn't include some of the other things from the National Osteoporosis Guideline Group. So in the UK we tend to use the NOG, National Osteoporosis Guideline Group. So this is what the FRAX looks like. You can log on at home if you just go on Google and put FRAX on your Google website, and you can do this yourself. So it's a WHO validated tool. This is years of data collected through Sheffield University, and you enter your age, sex, weight, height. Have you had a previous fracture? The National Osteoporosis Guideline Group doesn't include previous falls, whereas the Q risk does include a section on if you've had previous falls. And as I said before, falls are obviously a major risk for having fractures. Previous fracture, parental hip fracture, smoking status, steroids, rheumatoid arthritis, other secondary causes, which was that long list of medical list I had, alcohol more than 3 a day. You can put this in and it gives you a risk. Okay, so this is a 19% risk of a major osteoporotic fracture, or 7.1% risk of a major hip fracture over the next 10 years. And it's quite useful because what you can then say is you've got a 1.9% risk per year of a major osteoporotic fracture, or a 0.7% risk of a hip fracture each year over the next 10 years. You will then press the View National Osteoporosis Guideline recommendations, and they will tell you whether to take you on to do a bone density scan or not. And this is a good example of the advice that you get when you plug them in. So you will see, in terms of assessment of major fracture, if you fall in the red area, you go on treatment. You're high risk and you go on treatment. If you're in the green area, it's lifestyle and reassure. The middle area, you measure your bone density. And they've now included, as I said, a grading for steroids. So if you're on more than 7.5 milligrams of steroid, they give you a higher risk. If you're on a lower dose, as I said, 5 to 7.5 is not considered such a high dose and such a high risk. Your risk is lower. So this is a good example of a patient who we put in previously. If they're on more than 7.5, they definitely need to go on treatment. If they're on 2.5 milligrams of steroid, well, actually we would probably go ahead and do a bone density on them to try and decide. Okay. So this again shows you on the National Osteoporosis Guideline Group. It shows you major osteoporotic and hip fracture data, and it plots you whether you should be on treatment or whether you should have lifestyle advice. So there are lots and lots of treatments for osteoporosis. We talked a bit about the building blocks with calcium and vitamin D. There are hormonal treatments and HRT, estrogen replacement therapy, is obviously important and is helpful in preventing perimenopausal and postmenopausal symptoms. But we tend not to use HRT as a long-term fracture reduction treatment. And there's something called selective estrogen receptor modulators, or SERMs, raloxifene. Again, we tend not to use that because we actually have good treatments. So we have the oral bisphosphonates, and now we tend to use alendronate or risedronate. Risedronate has they're both weekly medications. You have to take them on an empty stomach with a glass of water, remain upright for half an hour afterwards. And some of the problem is about compliance with these medications, because you talk to people in clinic and you say, how do you take them? You say, well, I have my breakfast and then I take my tablets. They won't work if you do that. It's got to be on an empty stomach. So alendronate is a weekly tablet, empty stomach, glass of water, half an hour. important message to get across. Risedronate has slightly quicker onset of action and has a different tolerability to alendronate, so we do tend to change. And then there is ibandronate, which again we tend not to use that much, which can be a monthly injected or oral medication, but we tend to use other bisphosphonates called intravenous zoledronate, which is a yearly treatment that's a 15-minute infusion that we treat. And there's now other treatments that we use, something called denosumab, which is a 6-monthly subcutaneous injection that we use to treat. And all of these drugs up here are important because they are what are called anti-resorptive medication. So on your bone, you have two main types of cell. You have your bone builders, called your osteoblasts, and you have your bone destroyers or chewers, called your osteoclasts. Okay? And anti-resorptive treatments, so all these ones are focused on blocking the osteoclastic activity. So they stop the chewing away of the bone and allow building of your bone to happen unopposed. As opposed to some of these drugs at the bottom, which work by stimulating directly the osteoblasts. So they stimulate your bone builders. And teriparatide is what's called PTH, so it's a parathyroid hormone analogue, and that's an injection and that stimulates. So if you have really low bone density, your T-score, as we discussed, is very low, and you have had lots of fractures, or you have lots of clinical risks for fractures, then we can use this to try and build your bone up to a better bone stock and a bone density. And then after 18 months, 24 months of teriparatide treatment, we put you onto one of these drugs that then holds your bone there. Strontium ranulate we tend not to use so much now. It has dual action, so it has some anabolic building effect on your osteoblast, but it also has osteoclastic effects as well. But it carries with it some risk about clots, increased risk of thromboembolic and possibly cardiovascular, so it's something that we don't use that much now. So this is taken from NICE, and this just shows where the evidence is. And A means really good evidence, randomised controlled trial, drug versus placebo, that it works. And what you can see is the sort of market leader, the one that we all prescribe, alendronate, has grade A evidence of reduction for vertebral fracture, non-vertebral and hip fracture. Risedronate, the one that we tend to switch to if you don't tolerate alendronate, grade A across the board as well. And then the zoledronic acid and denosumab, what are called the parenteral treatments, so the injection treatments, they're also grade A across the board. In terms of men, not all of the drugs have evidence for, or grade A evidence for men, so we view men slightly differently and would view those on an individual basis. Okay. So, denosumab, so I'm just going to talk about this. So it's currently is NICE approved, so this is a 6-monthly subcutaneous injection. And it's NICE approved for postmenopausal osteoporosis, so primary and secondary prevention. And they're terms that you might hear people talking about. Primary prevention means that you've got clinical risk factors, you've got osteoporosis, but you haven't actually had a fracture. So we're trying to stop that first fracture, the primary fracture. Secondary prevention means you've already had a fracture, unfortunately, as we've said, that puts you in a higher risk group. So what we want to try and do then is prevent you having further fractures. So denosumab is licensed for both, and I'm going to show you a couple of little pictures, and this will help, I think, when I was talking about the bone builders and the chewers, the osteoclasts. So I won't go into too much detail, but in a normal bone, your builders and your chewers are working in harmony together, and there's a nice balance, and all your bones and joints, your skin, every bit of you is regenerating and being turned over and repaired, and your bones are no different. So these are done through various mechanisms, and what we can see is that there's a product called rank ligand that's a bit like a text message that sends between these to say you need to upregulate more chewing activity. But your body has a very clever way of adapting to that to create that control mechanism. And they have something called osteoporosis or OPG, and that sort of controls it. And that's your control mechanism, your buffer, if you like, and keeps the nice balance between bone forming and bone chewing. Unfortunately, as you go through the menopause, you lose the estrogen drive, and if you lose the estrogen drive, you get more rank ligand compared to the OPG, so the control mechanism gets lost. Okay, so the rank ligand stimulates more osteoclastic activity, so you get more bone loss, so you start developing osteoporosis. So denosumab is a very clever bit of biomedical engineering, and it's what's called a monoclonal antibody. And there may be some people here who are on monoclonal antibodies. We use them in lots of conditions now. We use them in rheumatoid conditions, we use them for treatment of multiple sclerosis, and they're also used in cancer treatments now. And they're human bits of protein that target mechanisms within the body. And you can see that this denosumab drug then binds to the rank ligand, so you've got more of the rank ligand, less of the OPG. So if you take out more of the rank ligand, you keep the balance more in order. So then you lose the osteoclastic function, allow your builders to kick in, and your bone density starts to come up. And it is a very good treatment. I'll show you a couple of slides on data. So this is a 3-year, so all osteoporosis studies happen over about 3 years. The reason for that is that it's not quick to show the change in your bone. It takes time to show the change, and therefore the drop in fracture. But what you can see, so this was at 36 months, this is about 3,500 people in the treatment arm, postmenopausal osteoporotic women, 3,500 people in the placebo arm. And you can see that in the treatment arm, you get a reduction of new vertebral fractures. So it's reduced from 7.2 in the placebo arm to about 2.3% new vertebral fractures in the denosumab treatment. So it's a 68% relative risk reduction. In non-vertebral fractures, so with things sort of wrist, ankle here, it's about a 20%. And in hip fractures, obviously the total numbers of hip fractures are a lot less, but you get still a 40% relative risk reduction. So these are good data. They're very equivalent to the intravenous zonandronic acid data, but it's convenient. It's an injection under the skin, and it's certainly a treatment that we've got plenty of patients on here. So to give it as a comparator, this is the data, the Horizon study data, looking at intravenous zeledronate. Okay, so this is the yearly treatment. Almost exactly the same study setup. 3 years, 36 months, 3,500 postmenopausal women in each treatment arm, treatment versus placebo. As we touched on at the beginning, the building blocks, everyone in these studies are replete in calcium and vitamin D. So they have all their levels made sure they're up and appropriate, and that's important. So what you can see is that the relative risk reduction in non-vertebral fractures is about 25% with zeledronate. It was about 20% with denosumab. The relative risk reduction of vertebral fractures was 77%. If I just go back, so 68% with denosumab, 77% with zeledronate, and the hip fracture reduction 41% with zeledronate, 40% with denosumab. So they're equal drugs. They work well. There's perhaps different tolerability, and the intravenous zeledronate we can't use in people who have significant renal impairment, whereas we can use denosumab a little bit more in people with renal impairment. So I'll just touch on some of you may be on denosumab. We've had quite a lot of political shenanigans with denosumab in, if we start it, will your GP take it on, won't they? What we have now got agreed, and this several months ago, that we will initiate the treatment if we feel it's an appropriate treatment, and then your GP will sign a contract with us to say yes, they will take on the subsequent prescribing. That is an agreement that is across all of Devon. If you're from Holsworthy, Stratton, Bude, at the moment the GPs have not signed up to that because you are with Cornwall CCG, but I am assured that that is coming, and that you also will be signing up to it and will be able to receive your care at your GP surgery after the first dose, which makes a lot of sense because to come up for a 30-second injection from Stratton or Bude, 2 bus journeys to get here seems a little ridiculous. So we are all systems go with that, and again, if you've got any other questions, Bev would probably be able to answer those questions. So very quickly, 2 issues that people often want to know about with bisphosphonate treatment in particular. So osteonecrosis of the jaw, so this a rare condition. I think there's a few key points about osteonecrosis of the jaw. The first is that this is a condition that happens in people who don't have bisphosphonates. So this is not just related to bisphosphonate therapy. The second bit is people who have poor teeth are much more, and bad dentition, are much more likely to suffer from osteonecrosis of the jaw. And all this came about from studies where we use, or oncologists use zoledronate, so intravenous bisphosphonates, in high doses much more regularly, every 6 weeks, 6 to 8 weeks rather than every year. And what they saw was that a few patients were developing this unusual condition called bone necrosis, death in the jaw, which is a very difficult condition to treat. That created a bit of a scare and a bit of a concern. Could we be causing that in some of our patients? As long as you are screened for your dentition beforehand and that you have good healthy teeth and you haven't had recent root canal treatment, so deep treatment, there is really no reason for you not to be on the bisphosphonate from our perspective. If you look at the studies, the denosumab study showed that in the treatment arm, and I showed you the freedom data, so in the treatment arm and the placebo arm, there were cases of osteonecrosis of the jaw, but actually every single one of them occurred in the placebo arm. So it tells you that it is a condition that happens anyway with people with poor dentition. But it is something we screen for, we think about, and it's important that if you have any concerns about it, you discuss it with us. The other thing that people have noticed, there was a trend 15 or so years ago that anyone who had a slight family history of osteoporosis, so mum was had a slightly curved spine, or at some point may have had a fracture but not really a significant fracture, that they went on bisphosphonates, whatever. And I think and hopefully I've shown that we now think about who needs to be on these treatments a little bit more than just blindly putting people on. The reason for that is what we've started to see is people who have gone on bisphosphonates, who have had good bone density, are suffering from fractures, and they're suffering from what are called atypical fractures. This is still an unusual occurrence, but it is something that makes us think, are you definitely needing to have been on bisphosphonates, and should we review whether you need to continue that bisphosphonate? And so the answer to that is we do that, and we think about holidays. In terms of atypical fracture, they often happen after minimal trauma. In the hips is most common, tends to be slightly lower than normal hip fractures, and they tend to be spiral fractures in the shaft of the femur, and they tend to happen on both sides, which doesn't sound terribly good. So we do think about this and we screen, okay? So this just gives an idea that all the resorptive medication are probably equally implicated in this, and I showed you on that nice list, the big list of treatments that work by inhibiting the osteoclast, the anti-resorptive. And this is an estimate, the number needed to harm NNH, so 417 patients over 3 years of bisphosphonates. So if you had 417 patients on bisphosphonates for 3 years, chances are you may get one atypical fracture. But we are thinking about it, we're doing more, we're being more proactive. So this is about the recommendations. So National Osteoporosis Guideline Group recommendations say if you're on oral bisphosphonate, alendronate, risedronate, you get 5 years. If you're on intravenous zoledronate, you have 3 years of intravenous treatment, and then we reassess you at 5 years. Okay, we look at your clinical risk factors, we reassess your bone density. If you've got low bone density, you're still osteoporotic, your T-score is less than -2.5, and or you've had further fractures, you stay on treatment. Your risk of an atypical fracture is not increased. If, however, your bone density has improved, which we hope, and you haven't had fractures, then we think about should we give you a period of time off the treatment, and we would then routinely take you off for a couple of years, reassess and make a decision whether you need to go back on. The only caveat to that is denosumab, because what we know with denosumab is if you stop it, you get what's called an accelerated rebound bone loss. So you built your bone up, you stop it, and it quite quickly drops down. So we think the main target population for patients with denosumab would be those who have had hip fractures and or multiple vertebral fractures that we're in reality never going to take them off treatment anyway. So then they should stay on denosumab lifelong, which is a good treatment for them. So, a little bit about male osteoporosis. This is taken from the National Osteoporosis Guideline Group, and again, just stratifies risk, number of clinical risk factors down this side, bone density, and whether you should treat or not. So we are thinking about men. This is a condition that is predominantly female, but we do think about men, and it's important that primary care colleagues are aware of this and we can think about helping there. So that's everything. Remember, get a bit of sunlight exposure, but don't get too much because we do have high rates of skin cancer in the southwest. What I would say is 15 minutes a day, forearm and face exposed, May through to September, without sun cream, and then go and put your sun cream on.